physiology and the anatomy of the respiratory system. Quick anatomical review. The thoracic cavity, of course, is bound by the thoracic vertebrae dorsally, the ribs and intercostal muscles laterally, and the sternum ventrally. The mediastinum is a space, it's an area between the lungs, and that's where the heart, trachea, esophagus, blood vessels, nerves, and lymphatic structures lie. Here's a closer up view of the mediastinum. So you can see the mediastinum membrane is indicated by the green area, and it outlines the gap in between the left and the right set of lungs. And that's, of course, where the heart is, where the trachea is, the esophagus, etc. Now the mediastinum, this is a normal x-ray here on the left of a dog thorax. The mediastinum, unfortunately, is a common place to get cancers. So mediastinal tumors are not uncommon in veterinary medicine. And when we're looking at a radiograph, so this is a normal thorax, we've got the heart, of course, the trachea, which is black. And then we have the aorta, the descending aorta. So the aortic arch coming away from the heart, the descending aorta, the caudal vena cava, and then, of course, cranial vena cava and the aortic branches as well through there. And then, of course, the dark area is the lungs. So that's normal. Abnormal, we can start to see here we have some modification of the trachea. So the trachea is not in its normal place. And where it should be all black, where the lungs are, we have a whole bunch of diffuse thickened tissue. So that's a pretty common look for a mediastinal tumor. So the upper respiratory tract, we've got the nostrils, the nasal passages, the pharynx, the larynx, the trachea. And if we get a little bit more specific, we have the nares, which are the nostrils. They're the external openings of the respiratory tract, and they lead to the nasal passages. We have the nasal passages themselves, which are between the nostrils and the pharynx. The nasal septum separates the left and right nasal passage. Hard and soft palates separate the nasal passages from the mouth. The larynx, of course, is an irregular short tube connecting the pharynx with the trachea, and it's made up of muscle and cartilage, and of course the larynx is also the opening to the respiratory tract into the trachea. The trachea is a wide tube that extends from the larynx into the thorax and divides into the two main bronchi, which we'll talk about with the lower respiratory tract. And that division between the two bronchi, so where the trachea divides to become the left and right bronchus, is called the bifurcation of the trachea. Upper respiratory tract is a common area for animals to have infections, so kittens and cats in general often get viral upper respiratory tract infections. Viral diseases such as herpes, to a degree calicium, can cause this accumulation of mucopurulent discharge in their nose and around their eyes. Rabbits are also common offenders. Rabbits commonly get upper respiratory tract infections as well, but theirs tend to be bacterial or fungal based as opposed to viral. Moving on down the way, the nose and the nasal passages, we have the turbinates, which are those little scroll-like bones. They divide each nasal passage into three main passageways, and of course we have a dorsal and a ventral passage. The sinuses are ciliated outpouchings of the nasal passages, so they are these little pockets of bone that are lined with ciliated epithelial cells, and they produce mucus. They're named for the bones that house them, so of course we have the maxillary sinus and the frontal sinus. And looking at a radiograph, this is what they show up as on a radiograph. It's harder to see the maxillary because it's superimposed by other bone, but the frontal sinus, you can see that it's this cavity within the bone that allows air to come in, swirl around, get humidified, and then make its way down the respiratory tract. Then we have the trachea, made up of C-shaped rings spaced along the length of the trachea to prevent collapse during inhalation. So that's why the trachea always shows up as black on X-ray, because it's always filled with air. And it has a mucus layer as well. Now it's important to note that the trachea It has a mucus layer all the way around the inside of the trachea, but this tracheal cartilage ring, it's not a full ring. So the tracheal cartilage creates this C, and then we have tracheal smooth muscle, which creates a little gap. So not quite a full circle. So with this, we can get some clinical abnormalities. Tracheal collapse is a clinical application. So when we look at the trachea, down here we've got normal trachea with C-shaped cartilage and then a pretty taut, smooth muscle layer. And then we start getting collapse. So this is grade 1 level of collapse, grade 2, grade 3, and of course grade 4. So this is a condition that's partially hereditary, so it's bred into the animal. The smooth muscle openings are larger. Each inspiration, the smooth muscle is sucked into the hollow part or the lumen of the trachea, and that's called inspiratory dyspnea. So they have difficulty, and they typically make this sort of honking noise when they're trying to breathe in. So inspiratory dyspnea, difficulty breathing in. It's common, very common in toy breeds. Yorkies are a key offender. Also, if they're overweight, it's more likely to happen. And if they overexert themselves, then that's typically when you see it because they're trying to get a faster respiratory rate and they just can't combat that collapsing trachea. Typical treatment is weight loss if they're overweight, exercise restriction, and then of course if they're a typical small fit dog in good health, then it would be surgery to place a stent. So if we go back to this image here, have a look at the trachea. So we've got the larynx up here, and then we can see this extreme narrowing of the trachea. So that dog on inspiration pretty much can't get air past that area. So that's a huge struggle, and that would be called inspiratory dyspnea, where they can't breathe very well on the way in. Surgery for that is to place a stent. So to place a structure that lines the trachea, that keeps the trachea open all the time. Components of the lower respiratory tract, we'll talk about the bronchi, which if we're talking about one bronchus, the left or right bronchus, it's bronchus is the singular term. Bronchioles, alveolar ducts, and alveoli. Essentially, each bronchus divides into smaller bronchi, which divide into even smaller bronchi, and then tiny little bronchioles. The bronchioles then subdivide into alveolar ducts. The alveoli are tiny, thin-walled little sacs that are surrounded by capillaries. The sacs are lined with a thin layer of fluid that contains a surfactant, and it's the surfactant that keeps these little alveoli open, so it keeps them inflated, essentially, with this fluid. Keeps them taut, otherwise they would be collapsed. External respiration takes place in the alveoli, and the oxygen and carbon dioxide are then exchanged between the blood and the air. Internal respiration we'll talk about a little bit later on. We're talking about internally exchanging CO2 for oxygen throughout all the tissues in the body and all the cells. So then we have this thing, the pleural space and the pleural membrane. So between the two layers of the pleura, which is that membrane that covers the thoracic cavity, between the two layers there's a potential space that's filled with a small amount of lubricating fluid. So that allows for continuous movement. It allows the lungs to inflate and deflate and move within this pleural space quite easily. The smooth surfaces of the pleural membrane, they're lubricated with the pleural fluid to ensure that the surfaces of the organs slide along the lining of the thorax quite easily. So as the animal breathes in, breathes out, they're not getting stuck on any portion of other tissue. So this is overall what the pleura looks like, and you can call it the pleura or the pleural membrane. Either is acceptable. And then within that, we've got the visceral, which is the innermost pleural membrane, the parietal, which is the outermost, and then this tiny little bit of fluid within that pleural space. All right, so getting down to business. The body's cells need oxygen to burn nutrients, to produce or to acquire and to take in that energy. The byproduct of this burning of nutrients is carbon dioxide. Single-celled organisms, they diffuse the CO2 for oxygen, so they create that diffusion process directly through their cell membrane. But of course, in complex animals, we're so big that our cells are not directly at the surface to acquire oxygen. We have cells all through the body that are deep. So in complex animals, we have a respiratory system and a cardiovascular system, which creates this symbiotic relationship. So the lungs and the heart work together to ensure that, of course, the oxygenated blood comes into the body, the oxygen comes into the body, and then that oxygenated blood actually gets pumped around the body. So overall, oxygen has to reach all of the body cells, and carbon dioxide has to be transported away from all of them. So you can imagine that this is as close as the cells in the lungs and as far away as the cells in the toenails, or just before the toenails. So these vital processes are carried out by the respiratory system working really, really closely with the cardiac system. So if the cardiovascular system is not working, one of the first things that we'll do is check their SpO2, which measures their blood oxygen levels to ensure that we are getting a good pump of oxygenated blood throughout the body tissues. So then we have internal and external respiration. External, the lungs and the pulmonary capillaries is what's involved. Internal is all over the body. So all cells, all tissues, every single portion of the body. Essentially, the true business portion is the internal. That's where every single cell and every single tissue is getting oxygenated. 2 steps are needed for respiration to take place in the animal's body, and that's the internal and external. External respiration occurs in the lungs. It's the exchange of oxygen and carbon dioxide between the air inhaled into the lungs and the blood flowing through the pulmonary capillaries. Internal respiration occurs all over the body, and it's the exchange of oxygen and carbon dioxide between the blood in the capillaries all over the body and the cells and the tissues in the body. Internal respiration, like I said, is really the business end. If this isn't functioning appropriately, then it doesn't matter how well the body's bringing oxygen in if it's not getting exchanged appropriately. And it's truly the means by which the body's cells receive oxygen and how they get rid of carbon dioxide. So again, they're both important, but the majority of the work is happening during that internal respiration. So let's look at pathway of air through the body. We talked about the upper and lower respiratory tract. So except for the 2 main bronchi that are formed by the bifurcation of the trachea, all the structures of the lower portion of the respiratory tract are actually located within the lungs. So essentially we've got upper, which is the larynx, the trachea, down right to this area, which is called the bifurcation. Definitely get to know that, the bifurcation. And then we have the branching of the right and left bronchus. After they branch, there's a small portion that's outside the lungs, and then all of the further branching of the bronchi into the bronchioles and the bronchioalveolar trees, that's all within the lungs itself. So air comes through the larynx when the epiglottis opens into the trachea. It gets divided into the left and right bronchus, and then it continuously gets passed down through the bronchioles and enters into the alveolar sacs. The bronchial tree, we call it the bronchial tree because they divide into smaller and smaller passageways, much like the branching of a tree. So if you imagine a bushy tree, the trunk represents the main bronchus that enters each lung, and then it divides into some fairly large branches, which divide into smaller and smaller branches that finally terminate in the leaves. The leaves, essentially, are equivalent to the alveoli at the ends of many branches of the bronchial trees. So after it enters into the lung, after the air enters into the lung, each main bronchus divides into these smaller bronchi, which divide into very smaller bronchi, and finally into the tiny, tiny little bronchioles. So we've got bronchus, bronchi, and then the smallest little end down here are our tiny little bronchioles. The bronchioles then continue to subdivide down to the smallest little air passageways, the very microscopic alveolar ducts. The alveolar ducts end in groups of alveoli arranged like little bunches of grapes. These groups of alveoli are called alveolar sacs. The air passageways that make up the bronchial tree are not just made up of rigid tubes. The diameter of each of these little bronchial passageways can be adjusted by smooth muscle fibers in its walls. So then it brings us back to the autonomic nervous system. So that automatic, that unconscious portion of the nervous system controls this smooth muscle contraction and release. During times of intense physical activity, the bronchial smooth muscle relaxes, allowing the air passages to dilate to their full maximum diameters in the process, and this helps the respiratory effort move the greatest amount of air back and forth to the alveoli within each breath. At more relaxed times, the fully dilated air passageways would actually create more work for the respiratory muscles to move air through gently. So at rest, when it's not under a huge exertion of physical activity, the bronchial smooth muscle partially contracts, reducing the size of air passageways to a more appropriate size. Sometimes irritants inhaled can stimulate severe bronchoconstriction, and that can make an animal, of course, have a really hard time breathing. So physical activity, we're getting bronchodilation, which opens up those bronchioles, ensures that air has an easy time coming into the lungs and into the alveoli. And during rest, we want to reduce that size of the bronchioles, so we're going to undergo bronchoconstriction. So, clinical application. Asthma is a common finding typically in cats. So it's a disease that causes the bronchial tree to become overly sensitive to certain irritants, and exposure causes inflammation with resulting thickening in the lining of the air passageways. It also often produces excess mucus and bronchoconstriction that can range from mild and annoying to severe and really life-threatening. Asthma, we don't see it as often in domestic animals as we do with people, but if we're going to see it in anybody, it's generally the cat, and it can be progressive over time. So asthma, it's important to note that there's no cure for asthma. We only treat asthma. And typically animals that are affected might show signs of severe dyspnea. So if they're having a really hard time breathing, they might look like this cat here. So having a look overall, cats who are having trouble breathing will do a few things to help themselves out. Typically they'll sit in sternal, so they'll be in their little button position with 4 feet on the ground and their chest typically on the ground or slightly raised. That's common for a cat who's having difficulty breathing. This cat too, you can see, has elongated his neck. So he's trying to gather more air, stretch out his respiratory tract to allow an easier passage of air. And what this cat will be doing is this continuous pattern of sort of like cough wheezing. And it's that continuous wheezing and that coughing that's indicative of asthma, along with thoracic x-rays. So again, it's made worse by allergens, and it's difficult sometimes to know what those allergens are. But once we know what the allergens are, or if we identify an area that the cat can't be in, if it's disrupting their asthma, making it worse, then we want to reduce those allergens as much as possible. Now, cyanosis, that word here, that's referring to blue mucous membranes, and that's when we're not getting an adequate amount of oxygen in peripheral tissues. Treatment for asthma depends on the severity of the case. Sometimes it could be daily anti-inflammatories, such as steroidal anti-inflammatories. Quite often it's prednisolone. And then we also have bronchodilators that either are daily or we give during the times of asthma attacks. In the end, of course, too, it's really important to minimize exposure so that we can reduce that from happening. So here's a cat getting its little titrated dose of a bronchodilator. So it's typically either a steroidal or strict bronchodilator type puffer with their own little chamber, which I love, tiny little cat mask. And one thing that's really important to note is smoking within the house or smoking in your car if you have a pet really increases their chances of acquiring asthma. It can also increase their chances of things like lung cancer or metastatic cancers, but definitely asthma. We've seen a lot of cats that have severe asthma and their owners are severe smokers. And I'm also happy to say I've had a number of owners who are so involved in their cat's life that they actually quit smoking because their cat developed severe signs of asthma. So it's something to think about if you smoke around your pets. Note that they also suffer the effects of secondhand smoke. Okay, so looking at the lungs are these sort of large dome-like organs, and they're kind of stuck to the rib cage. I know it sounds weird, but the way they are within the body, they're sort of glued more or less to the rib cage, and then they work with the ribs to inflate and deflate. So they're subdivided into lobes, and they're distinguished externally by visible grooves and clefts in the lungs. They're distinguished internally by major branches of bronchi, so typically we're distinguishing the lobes when we're performing surgery on these guys, and we're looking at them externally. Some basic pattern among species. Typically, there's 3 lobes in the left lung, cranial, middle, and caudal, and 4 lobes in the right lung, cranial, middle, caudal, and accessory. The exception is the horse. If we look over here, in the left lung, they have the cranial and the caudal lobe, and in the right lung, they only have the cranial, caudal, and accessory lobe. So the horse is a little bit different. The hilus, or hilum, I think with people we call it hilum, but with animals we typically call it hilus, is a small, well-defined area on the medial side, and that's where the air, the blood, the lymph, and the nerves all enter and leave the lung. So if we look at this image here, we've got our lobes of the lung all together, and then we have the hilus. So looking at the inside medial aspect of the lung, this is the hilus where the various vessels and the air also enters into the lung. Then we have the alveoli. So the alveoli are tiny, thin-walled sacs that are surrounded by capillaries, and the sacs are lined with a thin layer of fluid that contains a surfactant. External respiration takes place in the alveoli. Oxygen and carbon dioxide are exchanged between blood and air. The blood supply to and from the lungs is called the pulmonary circulation. Blood enters the lungs through the pulmonary artery. The blood in this large blood vessel is dark red because it contains very little oxygen, but a lot of carbon dioxide. So contrary to popular belief, deoxygenated blood is not blue, it's just dark red. And of course, through the walls of the vein, it typically looks blue, more so because of the connective tissue structures than the blood itself. It has returned to the heart now in the large systemic veins after delivering oxygen to the body's cells and picking up the carbon dioxide that was produced. So this CO2-rich blood enters the right side of the heart and is pumped out into the pulmonary artery by the right ventricle. The pulmonary artery splits into left and right pulmonary arteries and enters into the 2 lungs. Blood enters into the lungs from the right ventricle of the heart through the pulmonary artery. The vessels follow the bronchial tree and subdivide. The capillary networks around the alveoli exchange the CO2 for the oxygen. So structurally, as I mentioned before, the alveoli are tiny, thin-walled sacs that are surrounded by a whole network of capillaries. The wall of each alveolus is composed of the thinnest epithelium in the body. It's simple squamous epithelium. The capillaries that surround the alveoli are also composed of the same simple squamous epithelial cells. So the main physical barriers between the air in the alveoli and the blood in the capillaries are the thin epithelial walls of the alveoli and, of course, equally thin walls of the capillaries. So there's not much blocking the 2 of them. The 2 thin layers allow oxygen and carbon dioxide to diffuse freely back and forth between the air and the blood and continuously exchange. So fetal lungs in little baby animals in the body still are a little bit different. So fetal lungs, of course, are not in use. They're acquiring their oxygenated blood from the placenta and from the mother. So normal lungs, when we're looking at normal adult healthy lungs, the lung consistency itself is soft and squishy. It's really strange. They're light pink and they're very, very soft. They're very, very light. I kind of think of them as pink clouds. So they're this light pink, happy pink color, as I call. Spongy texture. Fetal lungs, because they're not in use, they have similar consistency to the liver. So this means that they're much more dense in texture, and of course they're non-functional. When the animal takes their first breath after birth, the surfactant in the alveoli fluid prevents the alveoli from collapsing. So they take that first breath, the alveoli expand, their surfactant fills the alveoli with a thin layer, and then that will forever prevent the alveoli from collapsing. One little test, that they can do if an animal dies after birth, if they want to find out if it was lung development related or not. After the animal's first breath, once that surfactant in the alveoli expands and prevents the alveoli from collapsing, it sounds weird, but that lung tissue should float in water because it's spongy and it's light. If the animal's lungs, if the surfactant did not spread through the alveoli and the alveoli remain collapsed, then it maintains that dense feature and that lung will sink. So sometimes during postmortem, if they're trying to identify if it's a lung-based issue or not, then they'll actually take a piece of the lung to see if it floats in water. Because if it doesn't float, it means that the lungs didn't have a chance and they didn't open up the way they're supposed to. So we're talking about now the lower respiratory tract. So looking at lower respiratory tract infections, the upper respiratory tract infections we talked about, they're much more easy to treat. They are based in the nasal passages and the pharynx and up to the trachea, or down to the trachea. Lower respiratory tract infections can be a little bit more challenging. So typically, a lower respiratory tract infection is called bronchitis or pneumonia. As its name implies, bronchitis affects the lining of the bronchial trees, so the bronchi and the bronchial trees. Pneumonia involves the tiny little bronchioles and alveoli, and in either case, the animal's condition is often more severe than with an upper respiratory tract infection because when inflammation occurs, a byproduct of inflammation to a point is fluid accumulation. So these inflammatory fluids tend to accumulate deep in the lungs in the small, dead-end little air passageways. The fluids are more difficult to cough up, and so they can actually accumulate and obstruct airflow altogether. Lower respiratory tract infections can be very, very serious and often life-threatening, especially if they're not treated. So bronchitis terminology, inflammation of the bronchial tree. Pneumonia is inflammation of the tiny bronchioles and alveoli, and typically with pneumonia, we're talking about residual fluid in the lungs. They are more serious than an upper respiratory tract infection, and they can become life-threatening. So if we look at this radiograph on the right, that's a normal canine or feline lung and thoracic structure. The heart looks a little bit big, so this is probably canine, but the heart looks a little bit big, to be honest. And then if we look at a lower respiratory tract infection, such as pneumonia or bronchitis, we can see this opacity, so whitening and thickening of all those bronchioles and alveoli throughout the respiratory tract, throughout the lungs. Okay, so much more severe. When they have inflammation like that throughout their bronchioles become constricted and they're not able to get full breaths of air. Function of the thoracic cavity overall is to create negative intrathoracic pressure, inspiration, expiration, respiratory volumes, exchange of gases in the alveoli, partial pressures of gases, and control of breathing. So negative intrathoracic pressure. Overall, the pressure within the thorax is negative in regard to atmospheric pressure. So positive pressure is when you blow a balloon up. So you're pushing air into a balloon, you're creating positive pressure. Negative pressure is kind of what would be happening to your lungs as you blow that balloon up. So you're releasing all air and it's under a bit of a suction. So your lungs themselves are under a mild negative pressure, which kind of means that they're suctioned closed in a resting state. So that partial vacuum pulls the lungs tightly out against the thoracic wall, and the soft, flexible nature of the lungs allows them to conform closely to the shape of the inside of the thoracic wall. That pleural fluid that we talked about before is between the lungs and the thoracic wall, and it provides lubrication for these kind of movements. As the thoracic wall moves, so do the lungs. So remember before when I said that the lungs are kind of stuck to the inside of the rib cage? It's true, and they're like this in part because of this negative pressure. So then as the thoracic wall moves, so do the lungs, and then the lungs follow passively as movements of the thoracic wall and the diaphragm alternately enlarge and reduce the volume of the lungs and of the thorax. So that's our inspiration and expiration. And it aids in the return of blood to the heart. The veins don't have this muscular pump to facilitate the process, so instead the negative pressure in the thorax helps return that blood to the heart. It helps pull blood into the large veins in the mediastinum, such as the cranial vena cava, the caudal vena cava, and the pulmonary veins. These veins return large volumes of blood into the heart, but have no muscular pump to facilitate that progress. So looking at inspiration, also known as inhalation, is the process of drawing air into the lungs. It results from enlargement of the volume of the thorax, and the lungs follow enlargement passively. Within this, air is drawn into the lungs. The main inspiratory muscles are the diaphragm and the external intercostal muscles. This video is also posted to our playlist. And you can note the change in size of the lungs and their volume upon inspiration versus expiration. So exhaling and inhaling. So you can see during inhaling, the rib cage is pulling the lungs out, so it's pulling the thoracic, it's enlarging the thoracic space, and the diaphragm during an inhale is pulling the thoracic cavity down, so it's opening up the lungs, both at the side and at the base. Exhale, everything goes back to that negative-based appearance and shrinks up. Exhalation, so during expiration, this, of course, is the process of pushing air out of the lungs, and it's opposite to inspiration. The size of the thorax is decreased, the lungs are compressed, and air is pushed out through the respiratory passageways. The main expiratory muscles are the internal intercostal muscles and the abdominal muscles. So you can practice this at home. If you take a really big breath in, is it easier to take a big breath in or release a big breath? So we'll try it. Taking a big breath in takes a lot of energy, a lot of effort from the muscles. Letting that breath go is almost the true reflex. So that in itself shows how the lungs are under negative pressure, and their natural position in resting phase is to be deflated. They're under negative pressure. The air is expected to escape the lungs. Likewise, take a big breath in, giant breath in, and try to identify the muscles that are working in the body. So we've got the diaphragm that is extending downwards, extending caudally, and we have those external intercostal muscles that are pulling the rib cage out, so pulling the rib cage laterally. Then during expiration, if you really push that air out, you'll start to feel your abdominal muscles engage. So that's a way, when you're thinking about it for tests, if you're being tested on the material, actually take a breath in and then push a breath out and see if you can identify some of the muscles that are at work. All right, respiratory volumes are standardized terms for describing the quantity of air involved in respiration. We have tidal volume, we have minute volume, and residual volume. So the tidal volume is the volume of air inspired and expired during one breath. The tidal volume varies according to the body's needs, and of course it's smaller when the animal is at rest and larger when the animal is excited or active. The minute volume is the volume of air inspired and expired during 1 minute, and it's calculated by multiplying the tidal volume by the number of breaths per minute. So an example, an animal with a tidal volume of 450 milliliters, that's taking 12 breaths per minute, we would multiply 450 by 12, which gives us 5,400 milliliters, which of course is 5.4 liters. So within 1 minute, they're inhaling and exhaling 5.4 liters. The residual volume is the volume of air that always remains in the lungs after maximum expiration. No matter how hard an animal tries, the lungs cannot be completely emptied of air. There's always residual volume. Clinical application. So we're talking about tidal volume. We're often using this to get an estimate of the size of the reservoir bag for anesthesia. When we have an animal under anesthesia, we typically are breathing for them. We're either breathing for them or we're just ensuring that there's a continuous, adequate flow of oxygen and anesthetic gas. Within this, we have to have a reservoir bag attached to the anesthetic machine. So I'll just skip to that right now. So the reservoir bag, as the animal breathes in their anesthetic through their circuit, when they breathe it out, it fills up the reservoir bag. And then that allows us to reuse some of the anesthetic gas within our system. So the reservoir bag, we have to ensure at least is bare minimum their amount of typical tidal volume. If we choose a reservoir bag that's too small, then there's potential when they take a breath in, they won't have enough gas to breathe in because we're relying on this recycling of reservoir bag gas. And when they breathe out, they might not be able to expire all their breath or all their air in their lungs because the reservoir bag might fill up faster than the disposal can take it out. So primary calculation, we typically use 60 milliliters per kilogram, and that gives us a rough tidal volume, or at least a rough bag size. So a rough idea of reservoir bag size. So an example, if we have a 10 kilogram dog, we're going to multiply it by 60 milliliters. That gives us 600 milliliters. 10 kilograms times 6 milliliters is 600 milliliters. So that's 0.6 of a liter. So we'll end up going with a 1 liter rebreathing bag. So that's very important. You'll learn a lot more about that as you enter into surgery, but it does have to do with the tidal volumes within the lungs. Now also, another clinical application that's really important during anesthetic, we have to ensure that the animal is breathing well. If they're taking very shallow, very poorly regulated breaths, then we worry that oxygen may not make its way to all of the alveoli within the lungs. If there's an area that's not receiving oxygen, and it could be because of trauma, or it could just be because the animal is not ventilating very well, then we might need to breathe for them using our reservoir bag. So we might need to force them to have a breath and create positive pressure inside their lungs. If we do not, and if we go through the whole anesthesia and later realize that they weren't properly oxygenating their lungs, that can result in atelectasis, which is alveolar collapse. Atelectasis. So atelectasis will happen over time if the alveoli do not have oxygen running through them or connected to them through blood supply, and the alveoli will actually collapse. Once they collapse, it's very difficult to bring them back. More clinical applications. Pneumothorax and lung collapse. So without negative intrathoracic pressure, normal breathing can't take place, right? Because remember I said when you release your breath, that's kind of like the negative pressure in your lungs taking over. Your body naturally is okay releasing a breath, right? It escapes the lungs because they're under negative pressure. If the air in the lungs leaks into the pleural space, so the space between the lungs and the thoracic wall, the partial vacuum is lost. The presence of free air in the thorax is called pneumothorax, and it results in the lung in that area actually falling away from the thoracic wall. So I said that the lung kind of sits stuck to the rib cage, that's the thoracic wall. In the case of pneumothorax, that air gets in between the lung and the thoracic wall, and the lung kind of falls away from that rib cage. Because now, nothing's holding it in place. So the negative pressure isn't holding it in place. This causes the lung to collapse, which definitely can be a serious life-threatening injury. The possible causes of pneumothorax and lung collapse are numerous. Sometimes it could be trauma, sometimes it could be cancers. Generally, the air comes from either the outside in the case of a penetrating wound into the thorax or from the lung itself. So if the lung has cancer within it, then it's going to rupture some of those little air sacs or the air-containing structures. Okay, so typically it's trauma, could be from the outside world, or it could be established in the lung. Regardless of the cause, the treatment for a collapsed lung consists of reestablishing that partial vacuum within the pleural space. So that can be done using a needle and syringe or suction, and of course, repairing the issue. So I mentioned that it could happen from within the lungs if one of those air-filled spaces sort of are collapsed or destroyed. So one thing when it comes back to anesthesia, I talked about us giving breaths to a patient using the rebreathing bag. When we give breaths to a patient, we always, always, always have to be extremely careful to stay within the natural pressures of the lungs. if we overinflate the lungs and we increase the amount of pressure in the lungs, then we can cause a rupture in the lungs, and this will cause pneumothorax. Okay, we do not want to be the cause of pneumothorax. It can be a long road for recovery, so that's something to always keep in mind. All right, so we're going to look at alveolar gas exchange and simple diffusion. So essentially, alveolar gas exchange relies on simple diffusion, easy peasy. So the area of high concentration to low concentration. So if we think about it, atmospheric air contains a high level of oxygen, so about 21% oxygen, and very little carbon dioxide, about 0.03%. When that air is inhaled down to the alveoli of the lungs, it's only a couple of thin epithelial layers away from the blood in the surrounding capillaries, right? We discussed it being that really thin, simple squamous epithelial cell layer. So it has potential to diffuse quite easily. The alveolar capillary blood contains very little oxygen, but a high level of carbon dioxide. So it gave up its oxygen to the body cells, right? And it's picked up their carbon dioxide as it's come back up through systemic circulation. So as this low oxygen, high carbon dioxide blood circulates right next to an alveoli or an alveolus that contains high oxygen, low carbon dioxide, something easy and amazing happens. Oxygen diffuses from the alveolar air, an area of high concentration, into the blood of the alveolar capillary, so an area of low concentration. At the same time, the carbon dioxide is doing the exact same thing. So the carbon dioxide is now diffusing from the capillaries, where it's picked up that deoxygenated blood, and it's going to diffuse its carbon dioxide into the alveoli and take its oxygen. So it's that continuous passing back and forth of diffusion from areas of high concentration to areas of low concentration. The differences in the concentration of the gases stay fairly constant because the blood is continuously picking up oxygen and dumping the carbon dioxide. So it flows away and it's replaced by more low oxygen, high carbon dioxide blood. At the same time, every time we breathe, we're replenishing this. Okay, so we can see the direction of the blood flow. We've got low oxygenated, high carbon dioxide blood, and then it comes into contact with the alveolus. Alveolus is singular for alveoli, which has lots of oxygen, low carbon dioxide. At this point, we're going to undergo that simple diffusion. Carbon dioxide is going to jump into the alveolus, oxygen is going to jump out into the bloodstream. And then, of course, we're going to exhale that low oxygenated air and the high CO2 air, and we're going to breathe in and start the cycle all over again. So breathing is controlled by an area in the medulla oblongata of the brain stem, so the very, very base of the brain, important for basic functions of life, and that is called the respiratory center. Breathing overall does not require conscious effort. Our breathing always goes into cruise control. This respiratory center directs timing and the strength of respiratory muscle contractions. The individual control centers for inspiration, expiration, and breath holding, and they can be linked to various factors. Breathing can be consciously controlled for brief periods of time, but overall, as long as there's nothing blocking the airway, the breathing will always kick back to normal. So you guys can go ahead and try that. You can try to hold your breath for a long period of time. After a while, your body's going to red flag you, and it's going to make you call uncle, give up, and take a breath. Because over a while, your automatic respiratory center is just going to kick in. Mechanical control for breathing operates through stretch receptors in the lungs, a preset and automatic system that involves nerve impulses center the respiratory center, which indicate when the lungs inflate to a certain point. Muscle contractions that produce inspiration are stopped. Muscle contractions to produce expiration are initiated. Another set of nerve impulses is sent when lungs deflate to a certain point, and at that point expiration is stopped. Process of inspiration is started. The net effect is normal, rhythmic, resting, breathing baseline pattern. So you can imagine, because this mechanical control relies on stretch receptors and back and forth sensory control and sensory receptors, when an animal is under anesthetic and we're overriding many of those sensory receptors, there is potential, of course, that their breathing patterns can change during anesthetic. And then, of course, if they're not regulating how much to breathe in, we always have to be very cautious about not overinflating the lungs during anesthetic. And then there's chemical control system for breathing. So the system itself affects breathing patterns only when something is out of balance. So this is continuously checking into the makeup of the blood. And it makes adjustments to maintain homeostasis. There's chemical receptors that monitor specific areas of the blood, so located in the carotid artery and the aorta, as well as in the brainstem. What the body's looking for or monitoring is CO2 content, the pH, and the oxygen. CO2, blood levels, and pH typically go hand in hand. So if we have an increase in carbon dioxide in the blood, then typically we start to get an acidic environment in the blood. So that means a decrease in pH. This will trigger the respiratory center to increase the rate and depth of respiration. Overall, we see this a lot too if we think about animals kicking into their natural form to accommodate and sort of maintain homeostasis. Animals who are in ketoacidosis. So we talked about that in our renal lecture. Ketoacidosis is when the blood becomes an acidic environment. Typically, we see it associated with diabetes. Dogs who are in a diabetic ketoacidosis state, their blood is more acidic than neutral, and you'll see them panting quite significantly. So the panting here is a compensatory mechanism. Decreased carbon dioxide in the blood increases the blood pH, so it brings it up to more of a neutral or borderline alkaline level. This triggers the respiratory center to decrease the rate and the depth of respiration. Oxygen variations in the blood, so the effects of variations, they're not quite as clear as with CO2. Slight hypoxia, so a lack of oxygen to some degree. The respiratory center is, of course, signaled to increase the rate and the depth of breathing. And we see this in any animal who's having difficulty acquiring oxygen. We always see an increased respiratory rate, so they're trying to bring in more oxygen to a body that's possibly failing them. Severe hypoxia, the neurons of the respiratory system become so depressed that impulses can't even be sent to the respiratory muscles. So this can cause breathing to decrease or stop completely. So keeping that in mind, when an animal is freshly dyspneic, so they've come to you, they're showing signs of respiratory distress, quite often we're seeing an increase in respiratory rate because they're still trying to compensate and acquire more oxygen. Long term, of course, their respiratory center just ceases. Their respiratory system just gives up altogether and they stop taking in those signals. So, of course, animals that are dyspneic are always sensitive cases. They always could die at any point. I know that's really evil to say and awful to say, but it's a reality because they're maintaining this fine balance of compensating through breathing so heavily and so quickly until the point where their body becomes exhausted and their respiratory center in their brain just gives up. Other things we want to watch out for too, so I talked about panting as a way to maintain homeostasis in regard to getting rid of some of the carbon dioxide. Also too, if we see an animal yawning, we know that yawning, of course, can be boredom, it can be stress, but yawning, typically for us, yawning is an indication that we need to take a big breath, that we need to increase the amount of oxygen in our blood. Sometimes we can see that too, to a lesser extent, with dogs who sigh a lot. So they take in that big breath and then just sigh. That's also an indication that we have a minor change in oxygen levels. And that is all.